Hello, my name is Dr. Dewan S. Raja. Today I will discuss about squamous cell carcinoma. Squamous cell carcinoma is a malignant tumor of keratinocytes arising from epidermis, often associated with cumulative ultraviolet exposure. Definition: a malignant neoplasm of squamous keratinizing cells of the epidermis or adnexal epithelium. Second most common type of non-melanoma skin cancers after basal cell carcinoma. Epidemiology: common in fair skin individuals with chronic sun exposure. In particular geographical location like that of the southern United States, Texas state, also in Australia. Peak incidence: elderly men, especially on sun-exposed sites. Immunosuppressed patients, that is organ transplant recipients, HIV patients having increased risk. There are multiple risk factors like ultraviolet radiation, cumulative sun exposure, tanning beds, precancerous lesion, actinic keratosis, Bowen's disease, leukoplakia, chronic inflammatory scar, burn scar, chronic ulcers, osteomyelitis sinuses, we call it Marjolin's ulcer, immunosuppression, transplant patient, HIV, chronic steroid exposure, human papilloma virus infection, especially anogenital squamous cell carcinoma, human papilloma virus type 16, 18, 31, 33, chemical carcinogen, arsenic, tar, hydrocarbon, radiation exposure. So these are the risk factors for the squamous cell carcinoma. Clinical features usually arises on sun-exposed skin, face, ear, lower lip, scalp, dorsal hands. Lesion type: nodules with central ulceration and raised indurated edges, or scaly crusted plaques, non-healing ulcer or wart-like growth. Tender firm erythematous nodule is the most common type. Can metastasize, unlike basal cell carcinoma, to lymph nodes and lung. Histopathology: keratin pearl, rolled concentric layers of keratin, atypical squamous cell invading dermis, varying degrees of differentiation, well differentiated, moderately differentiated, or poorly differentiated. Prognosis depends on site, size, depth. Differentiation: perineural invasion, high-risk site, lip, ear, genitalia, and scars. Overall, good prognosis if detected early. Metastatic rate is around 5%. Okay, so these are the morphological features of squamous cell carcinoma. You're seeing nodule here. Okay, scar and ulcer and scar here. So in the histopathology, you'll see pleomorphic squamous epithelial cell. Epithelial cell is different shape and size, pleomorphic, arising from epidermis and extending into the dermis like this. Central keratinization surrounded by concentric layer of abnormal squamous cell. That is called keratin pearl. Another one is here, another one is here. We'll get keratin pearl. So these are the features of squamous cell carcinoma. Okay. It may be nodule, it may be an ulcer, it may be scar. And we'll get epithelial changes here. We'll get keratin pearl and the epithelium will progress towards the dermis. Okay, so again, sheet patterns. keratinization, keratin pearl, intercellular bridge creating mosaic pattern, intercellular cellular bridge like macula adherens, junular adherens, eosinophilic cytoplasm. Okay, we'll get in the squamous cell carcinoma. Management, surgical excision, wide local excision, Mohs micrographic surgery for high-risk sites, radiotherapy alternative in non-surgical candidates, topical therapies for in situ lesion like bounce disease, 5-fluorouracil, imiquimod, systemic therapy, advanced metastatic disease, immunotherapy, PD-1 inhibitors such as semiplimab or pembrolizumab, chemotherapy like cisplatin 5-FU, less commonly used. Okay, and that's all about squamous cell carcinoma. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.